Good afternoon. I'm Dr. Elizabeth Stevens, and I am a pediatric and congenital cardiac surgeon here at Mayo. I'm joined by Dr. Yasser Qureshi, who is a pediatric cardiologist with additional training in advanced imaging. We both have specialties in vascular rings, and we're excited to discuss this topic. Throughout this webinar, you can actually put in your question in the QA portion. So we'll be looking for those questions and answering them most likely at the end, but please do put your questions there. And Yasser, maybe we should start by covering the types of vascular rings, and I know you have some images to help explain them.
Yeah. Thank you, Elizabeth, and welcome all to our webinar this afternoon. We're hoping to have a good session discussing about the most common vascular rings. We'll talk about the anatomy, the management, and then don't forget to ask questions through the Q&A portion of the webinar. So we'll start with this. The first, the two more common vascular rings are double aortic arch and the right aortic arch with the aberrant left subclavian artery. So we'll start with this first one, which is the more typical one, where you can actually see the blood vessels essentially all around the trachea and esophagus, and that's the double aortic arch because we have the normal left-sided arch and the right-sided arch, both of them joining together at the descending aorta and then creating a true vascular ring around the trachea and esophagus. As you can see, the trachea and esophagus are really getting strangulated between these vessels, and that's where all the clinical symptoms in these patients also arrive. Now, just going over through the anatomy a little bit further, you can see that both arches basically give rise to the branches, their corresponding branches. So the right arch gives the right common carotid and the right subclavian artery, and the left arch gives rise to the left common carotid and the left subclavian artery. Most of the time, there's one arch which is going to be dominant, and most commonly it's going to be the right arch which will be dominant. And that's advantageous when one arch is dominant because the other one can be sacrificed during the repair. If they're both similar in size, that can actually be problematic. So most commonly, like I said, the right arch tends to be more dominant. And the ductus arteriosus in these patients with double aortic arch is typically on the opposite side of the dominant aorta. So if it's a dominant right arch, the ductus will be left-sided, which is the more typical configuration. But if there is a dominant left arch, then you have a right ductus arteriosus. The important thing over here is the recurrent laryngeal nerve that goes right around the left arch. So you can see why this is important, as Dr. Stephen will have to fix this, trying to avoid any damage to this nerve. Here are some CT examples. CT is the most definitive way for us to assess the type of aortic arch and assess its effect on trachea and esophagus to some extent. So in the top panels over here, we're seeing the double aortic arch where you have the left arch and a right arch. The trachea goes right in the center, and you can see all four brachiocephalic vessels arising from their corresponding arches. This view, we're basically looking from the head down through the barrel where the trachea and esophagus will lie right in the center. And this one is from the side, from the left side, looking at the left arch, and in the background we can see the right arch, similar to the picture we saw earlier. Over here, you can see the trachea right in the center of the right aortic arch and the left aortic arch, which are being cut in the short axis over here. You can also notice that the right aortic arch, in all of these pictures, you can see that the right aortic arch is typically slightly more superior than the left arch. That's not to be confused with a cervical arch, because the right aortic arch is always going to be a little bit higher than the left aortic arch. A true cervical arch is when it goes all the way up into the cervix, meaning the neck. So this is certainly not a cervical arch. Now, very commonly, one of the portions of the non-dominant arch can be atretic, and that's what you can see in this picture. We have a dominant right arch. We're kind of looking at this CT from the back and slightly to the left side. As the descending aorta comes down here, you can see a little bit of bird beaking, or this pointing thing right here. That's where there is another ligament in between the left subclavian artery and the descending aorta. So that's where an atretic segment of the double aortic arch exists, and that's another ligament that the surgeons will have to transect at the time of surgery. So even though it may look like it's just the right arch and the normal kind of like a bifurcating first branch, it's actually a left arch with an atretic segment. And then here's an example of a dominant left arch and a smaller right arch. So this is less common. The most common one, like I mentioned, is a right dominant arch in that setting. Moving on to the other most common vascular ring, and this is probably the most common vascular ring, that's the right aortic arch with aberrant left subclavian artery. So here you can see the right arch again exists, and then on the left side, the first branch, instead of having an innominate artery, basically only giving rise to the left common carotid artery, and the left subclavian artery arises posteriorly from the descending aorta, usually through a diverticulum of Komarov, which gives rise to the left subclavian artery. So how does this constitute a vascular ring? Well, the thing that really makes it a ring is the presence of ductus arteriosus. Now, in most patients in the postnatal life, there's not going to be a ductus arteriosus. It will really be a ligamentum arteriosum in this area that actually completes the vascular ring that strangulates the trachea and esophagus in the center. So again, another form of a typical vascular ring where you have the right aortic arch on the right side, the left common carotid and ligamentum arteriosus on the left side, and posteriorly you have the either diverticulum of Komarov or a portion of the descending aorta, which causes the compression in these patients. Here's another model that kind of shows exactly how, looking from the front, it will look like. You have a right-sided aortic arch. The first branch actually goes to the left side, so that's important when we're doing echo imaging, that we look for the first branching pattern going to the left side. And this one does not bifurcate, as I mentioned earlier, into like an innominate artery. Instead, you have the left subclavian artery coming off all the way from the back, from the descending aorta, via a diverticulum of Komarov, and that would give rise to the left subclavian artery. This diverticulum of Komarov is really just the dilated proximal portion of the left subclavian artery, or the dorsal aorta on the left side, that persists. Before the baby is born, in utero, all the cardiac output is going through the pulmonary artery, across the ductus arteriosus, through this diverticulum of Komarov, down the descending aorta. That's the reason why this vessel is so big as compared to the rest of the subclavian artery. So that's the origin of the diverticulum of Komarov. Elizabeth, you brought some 3D models for us.
Yeah.
So you want to
That was a great
show
summary.
us?
Yes, sir. No, we do. I wonder if I should just start with, this is the one we were just talking about. So this is the right arch. So if you concentrate on the kind of dark orange, that's the aorta that's swinging to the right. And here's trachea here, that yellow. If I turn it around, you can see the aorta coming down the back and the subclavian right here. There's the Komarov's diverticulum, and that is the ligamentum right there. Here, I'll use a pointer to try to, right here. So if you look at on the side, you can appreciate trachea in yellow, very compressed, esophagus in that tangerine color. And then I'll show you, this is actually a patient who had right arch, aberrant left subclavian, had a repair at another institution, but still was having symptoms. And you can appreciate, so she had a ligamentum release. Let me see if I can angle this appropriately. So if you look right in there, you can see, here's the cobrals diverticulum here. Here's the subclavian, and you're sitting right on the spine there. There's the esophagus. Let me get it a little better. Esophagus that's having trouble getting compressed. So even though the ligamentum was released, she still had compression of other structures. And in here is the trachea in blue. That's a little harder to see. And then I want to show you the double arch model. So this one, if you look from, let me get you oriented. Okay. So here we have the aortic arch coming up. We have a right dominant arch here and a left that's not dominant. And then this is the area where it connects. So that's the left arch connecting to the right, coming down. And there's the airway here, and esophagus. All right. So many of these diagnoses are coming through the pediatrician or internal medicine, even emergency. Can you talk through imaging and how these come to light?
Yeah, that's really important part because the primary care providers or even the ER physicians are really at the front line to actually make the diagnosis of these patients. And if they don't come to us, we can't really evaluate those any further. So it's really important to pay attention to details, to things that can be helpful in identifying these vascular rings, because sometimes these symptoms can be pretty subtle. One of the things that let's look at it from the anatomic perspective. We have the trachea and we have the esophagus, that both of them are getting compressed between these vessels. So you can have symptoms from either one. You can have symptoms because of tracheal obstruction, which are usually more dramatic and will bring to attention a lot more quickly. And those symptoms could be simple things like noisy breathing, croup, coughing, repeated pneumonias. Some patients will actually get diagnosed with asthma. So that's one of my pet peeves that I tell our residents and trainees, that, if you have a new toddler with the diagnosis of asthma with no family history of atopy, no asthma, no allergic rhinitis or atopic dermatitis in the family, and only the toddler has asthma, think of vascular ring. That's really an important thing, that because a lot of those symptoms may be pretty subtle, and anybody who's having a little noisy breathing and will get diagnosed with asthma and try inhaler and things like that, and they don't get better. So that should again be another reason for you to actually assess further. Now, coming from the esophageal compression standpoint, those are a little bit more subtle, especially in children. Where adults can actually, tell that they're having dysphagia, or they can't really swallow more easily. The children are sneaky in the sense that they can actually look at, they learn how to swallow with those rings, so they know exactly what they have to do to actually make it easy for them to swallow. They take smaller bites, they flush down with water, and those are the kind of things that you'll actually have to ask the parents that, they're asymptomatic, but when we ask them directly, what are the kind of things that the child really likes to eat, they will never pick anything that is sticky, and they will actually say, my child avoids peanut butter because it kind of gets sticky and they can't really flush it down with water. Or every time they take a bite of steak, they have to drink half a glass of water. Things like that should be actually a clue that there is some dysphagia that is happening. In babies, sometimes another important thing to remember is that because of the esophageal obstruction, they can have pooling of saliva or secretions in the upper part of esophagus. And then that can, when they're lying down, that can continue to trickle down into their trachea, and that can actually increase, can present as coughing spells or even repeated chest infections from that reason also. Those are more dramatic presentations, but a lot of these patients are nowadays even asymptomatic. But let's say, we have some symptom, whether it's tracheal obstruction symptom or esophageal obstruction symptoms. How do we evaluate? Well, one of the simplest things that you can do is a chest x-ray. So if I go to here, so a simple chest x-ray, the important things to look for is where the aortic knuckle is on a chest film. So you can see the air in the trachea, and the normal trachea will be slightly to the right side, and then you'll have this aortic knob or indentation into the air column in the trachea on the left side. So that tells you that this is the left aortic arch. As opposed to the right aortic arch, where you can see the air column in the trachea being indented to the left side, being pushed to the left side, and the indentation is from this right-sided aortic arch. So a simple chest x-ray can kind of give you a clue that there is some arch anomaly. It doesn't give you 100% of what's happening, but it will raise your suspicion about, you need to look further. So here again, you can look at the comparison that the normal left aortic arch is a little bit inferior, whereas the right aortic arch is a little superior, but it's still not going all the way into the neck, hence it's not a cervical arch. On the lateral view, you can see that the inferior part of the trachea is usually pretty straight. You can see there's really no angle here in this portion. But if you look over in this patient with the double aortic arch, as the trachea, one of the arches is traveling behind the trachea and esophagus, it causes an indentation, and it's almost a bowing of the inferior part of the trachea over here. So that's, again, another clue that there might be some arch anomaly. Does not necessarily tell you exactly what is going on, but it is important to recognize that. And if you are more suspicious, another thing that is commonly available is the barium esophagram. In the barium esophagram, you let the patient swallow barium, and you see the esophagus. And if you have a right-sided aortic arch, you'll see a rightward indentation. If you have double aortic arch, you see an indentation on both sides. Again, you can see the right arch being a little bit superior than the left arch. And then in any patient, and this is a patient with double aortic arch, you see a big indentation on the lateral view posterior to the esophagus. Similarly, in a right aortic arch with the barren left subclavian artery patient, you see an indentation on the right side, but also an oblique indentation that goes leftward and superior. That's the aberrant left subclavian artery as it's traveling right behind the esophagus and then goes to the left arm. Contrast this with the double aortic arch. The leftward indentation was inferior. This one is superior to the right aortic arch. Once again, if it's really just a barren left subclavian artery, you'll see a smaller posterior indentation on the lateral view, but that's not always true because, if you have a large diverticulum of Komaro, it may look something like this as well. Now, a lot of the new diagnoses are actually a fetal diagnosis. The asymptomatic patients, because of the change in how the obstetric ultrasound is now being done, we're picking a lot more prenatally diagnosed vascular rings. And most of these patients actually tend to be asymptomatic. And that's where it becomes a question of when to operate on those patients, what is a good timing. So Elizabeth, I'll ask you, about the general management of vascular ring first, and then maybe you can talk about something about how to deal with patients who are asymptomatic truly.
Yeah, so that's a great point. So we're meeting these families during the pregnancy. We have a idea of the anatomy that is finalized, after the baby's born, but we have a pretty good idea of what the type of vascular ring that they have. And of course, then once the baby's born, the parents are watching them and seeing how they're doing, and they're able to do normal baby things. But over time, some symptoms can develop the parents are watching for. So let's maybe start with double arches, since this is the one that presents the earliest with symptoms. So this, again, you'll recognize this diagram from previously, but it has shown here again, in this case, a right arch that's dominant and then a left arch. And these tend to be tighter. They tend to have more symptoms earlier, respiratory and esophageal symptoms. So what do we do for these patients? We're actually going to be dividing in this area where the red line is, dotted line is, and also dividing the ligamentum. And I'll show you that on the next slide. So this is showing the surgical repair. So the ligamentum is already divided, and now we're putting clamps here, and we're dividing this part of the distal left aortic arch. So this is the accessory arch, and again, the baby has enough flow going the right way, the right arch, to provide it to the descending aorta. And so shown here, you can see the aorta provides blood. It goes up to the head and arm on the left side, and then similarly on the right side, and then the blood comes around here into the descending. So these patients are virtually everybody's getting repaired, usually less than a year, and we expect symptoms quite early on those patients. So I'll move on to the next one. So we looked at this anatomy previously, and this anatomy can be a little more tricky in terms of when they present with symptoms and when they should be repaired. So again, this is the right arch. The left subclavian, the cobrous diverticulum is generally right here. And so generally speaking, if you have a large cobrous diverticulum with this left subclavian, over time we see the vast majority of these patients developing symptoms. Often it's not until they're having solid foods and a little bit older. And so we've, as a specialty, been considering, when to repair these. Like, we would rather not have a child have chronic tracheal and esophageal compression. We think the longer you have this, the more likely you'll have things, longer term consequences. And so at least in our hands, and we do a lot of these, I think the optimal timing of repair in terms of the, pain, the child's tolerance of the operation, recovery, and also the technical ability of the operation, I would say it's about 1.5 to 3 years. Again, this is, it's easier to repair when they're age. It's at that age, it's easier to spread the ribs and do what we need to do. The children don't remember anything about the surgery or the hospital when they're older. They heal very quickly at that age. So that's, a discussion obviously with the families, but the vast majority of families are electing for a repair in that time period, and many of them by then are already having, recurrent viral illnesses, can have slower eating and preferences to more softer foods and things like that. But again, of course, this is a discussion with the family. It's interesting that even for patients who the parents say we're really not noticing respiratory-wise, when we look down with a bronchoscope during the repair, we see about 30% compression externally. So as Yasser said, these kiddos compensate. They're used to their anatomy. They've never known anything different. So many of them are having significant compression, and we just don't see clinical signs of it. And then I just wanted to show this is also how the repair is done. So again, this is a right arch. Aberrant left, you can see the cobrals. So we move the subclavian to the carotid. This is an operation we do quite frequently. You are working on the carotid. We've never had any neuro events or anything like that. And this makes sure that that area behind the esophagus and behind the trachea is widely patent. For older, larger patients and adults, the operative repair is more complex. So to get to the carotid in the chest in an adult, so like if we go back to this model, maybe we can zoom in on this. They're getting to the carotid up here. Let me see if I can get you back in the center here. All right, great. Thank you so much. So to get to the carotid up here, if you're going through the chest in an adult, that's a very deep way and a long way to get all the way up there. So that's very challenging. So we frequently have our vascular surgeons help us, and what they can do is put the subclavian onto the carotid in this, working in this area, so just above the clavicle. I'll use my pointer, just in here. And that takes care of the subclavian. And then in older adults, we're actually replacing the aorta, so this part in here that's involved in the vascular ring, because by that time you've got atherosclerotic disease, you get your common diverticulum is not as good tissue, and so again, repair in adult is more challenging, and it does require the heart-lung machine. So that's another reason that we do feel like if they're going to have surgery, can we do it when it's easy and the kids will remember it and it's relatively low risk.
Surgical ease is obviously important, but from a pediatric cardiologist standpoint, for me, one of the most important thing is that many patients who are asymptomatic early on, they develop symptoms in their teenage years. And by that time, the tracheal ring, and those things that the trachea has developed under this external compression.
Yeah.
So even after release of that external compression, their trachea is still not completely normal. And that's and the same thing can happen with esophagus also. So that's the other thing that, doing it early on while the child is still growing can actually have certain benefit from the developmental standpoint as well. So.
Well, we maybe we'll pause here. We have a question. Can you clarify what symptoms an infant might present with and what would happen if untreated?
Yeah, so, in infancy, most of the patients, if they have symptoms, they're going to, especially in the neonatal time frame, as soon as they start breathing, you'll start having noisy breathing, or you can have stridor, you can have, cough and repeated spells where they aspirated or choked and had to be seen in the emergency rooms because of these frequent choking spells because they just couldn't swallow properly. So that's one of the things that they can present with. But from the esophageal dysmotility standpoint also, like I said, one of those problems could be just pooling of secretions, and that's one of the situations where we can encounter in NICU where a child is repeatedly getting, suction because had pooling of secretion in the upper part of the esophagus that aspirate and cough and, becoming hypoxic and things like that are developing. Although, like I mentioned early on, many of those patients who are we now diagnosing prenatally before they're born, they actually don't have any symptoms, and you actually have to check for those symptoms periodically as the child starts eating, and especially solid foods and table food, because those are the ones that are actually going to elicit symptoms of esophageal dysmotility if they didn't have any respiratory infections. The respiratory symptoms are going to bring them to attention a lot more easily than esophageal symptoms in general.
Yeah. I also feel like I've seen, especially in the teenagers and young adults, that diagnosis of GERD, which tends to go away after surgery. So they've been put on reflux medication. And like you said, very frequently to be diagnosed with asthma, exercise-induced asthma, and then, it goes away after we have, do a repair to your point.
A lot of teenagers will present with just exertional dyspnea because again, there's there is at least 30% of narrowing of the trachea, which at baseline nobody has any symptoms, but when they're pushed in high school sports and things like that, then they manifest that I can't keep up with my peers. So that's another thing that can actually present in teenage years. But again, at that point, it may or may not get better with the surgical repair, and the same thing in the adults also. We always counsel them about that yes, the surgery will relieve the external compression, but it may not return to like 100% caliber and things like that.
Maybe it would be good to talk about some more complex rings. We've talked about kind of the most basic and most common, but something like a circumflex aorta or something like that, some of these more complex ones.
Yeah, so circumflex aorta can occur in combination of other arches. And so what the problem in that is that essentially you have a transverse aortic arch that is more horizontal and is going behind the esophagus because the dorsal aorta, the descending aorta, is on the opposite side of their dominant arch. So if you have a right aortic arch, you have a left-sided descending aorta. How does it connect? It connects through an arch that's actually traveling behind the esophagus. So that's a bigger deal because even if you relieve the vascular ring, you still have a big vessel that's traveling behind the esophagus. So you can continue to have symptoms because of that. So in those situations, you have two options. One is, you do some sort of a PECSI where you attach, trachea or esophagus in the opposite direction, or you do a very complex repair, what we refer to as the aortic uncrossing procedure. And Elizabeth, you know better about those things than I do.
Yeah, well, that's a good point. Aortic uncrossing is very uncommonly done, and it's for severe symptoms and for circumflex aorta. But to just explain what Yasser was describing, one of the important things is how, if we could also zoom in on this guy, so how the spine relates to the aorta. I'll move you back in. Thank you so much. So if you look here, you've got the spinal column right here. And so what Yasser is talking about is the aorta is starting on the right, and on this case, it ends on the right. But a circumflex aorta, it starts on the right, and as it goes in this area behind the esophagus, behind the trachea, it then comes and ends where my finger is here. I'll put a pointer. So that crossing point, where it crosses, is often very close to the carina, right there. So you end up, even if you repair the ring, you have aorta behind the carina that's going from one side to the other. So that's what defines a circumflex aorta, and that's what can be tricky, because even if you repair the vascular ring in a normal way, you still have that mass effect, because again, you have the spinal column right here, and you have limited space. So just to explain that part further.
And in the PECSI, what exactly do you do
Oh,
with the
yeah, the
trachea
PECSI,
and
yeah.
descending aorta?
So if you look, again, thank you so much, at where this spine is right here. So a PECSI means that the aorta, we're going to move it a little to the one side or the other. So often the right arch is coming around and it's coming a little too far to the left and in our way. So we'll put little sutures and move the aorta a little bit to the right to keep it out of the way. And then they'll put, with our ped surgery team, they also put sutures of the carina or the main stem bronchus, and they put sutures to pull that back. So we mobilize the esophagus out of the way, and then we put sutures on the back wall of the trachea to open that up. So these tracheas and the bronchus can get very narrowed, slit-like, and those little sutures open it up more like a circle. So those would be called an aortopexy or bronchopexy. So those are like adjuncts.
And for the aortic uncrossing procedure, that's obviously a bigger procedure, and you really have to weigh in the risk versus benefit in those situations. So while the simpler repairs obviously are favored because, they're less complex, and even for moderate symptoms, it's easily justifiable. Whereas an aortic uncrossing procedure, you have a higher risk, a bigger operation, How do you decide about doing one versus the other?
There's a number of risks related to the uncrossing, and it basically brings the aorta. Let me get you back in the view. There we go. So it brings the aorta from the right side, and it brings it over to the left side. So you have to dissect the whole aorta and bring it from in the back in here, bring it around so it's like a natural left aortic arch. The problem or the challenges with that are both phrenic nerves are at risk, recurrent laryngeal nerve is at risk, and it can be very challenging to get that aligned just right so you don't also have actually the esophagus take an undue turn and have actually esophageal symptoms after. So even though conceptually it sounds great, like, oh, I'm going to recreate a normal aorta, the results of the risks related to it are higher. So we usually are working to look at the anatomy really carefully to see if they're a candidate for a regular vascular ring, like plus or minus a pexy, because you can put those sutures in and move the aorta some. And then if they're really struggling with symptoms and their anatomy is really circumflex, where you see that the anatomy is not going to be amenable to vascular ring repair with the adjunct, that's kind of when you have to discuss with the family on crossing.
Mm-hmm. I see. All right.
It looks like there was one other type of kind of sister vascular ring. We call it a sling. Do you want to go over what that anatomy is?
Yeah. So, you know, one of the probably the most common arch anomaly is where the arch is actually on the left side, but only the left subclavian artery is arising, aberrantly from the descending aorta. So I have some pictures of that. So here on the CT, you can see the aorta is on the left side, but then you have the left subclavian artery coming off which is crossing behind the trachea and esophagus. Now, this is not a true vascular ring because this side, the left side, is actually free. The right side is actually free. So the arch is on the left side. The ligamentum arteriosum is also on the left side. So there's really nothing closing this complete. It doesn't really make it a complete ring. And this is what sometimes people refer to as incomplete ring, but a sling is probably a better term to kind of describe that. Most of these are actually found incidentally for a CT done for some other reason. But when we do discover that, and very rarely there is symptoms, it's really because of the these are esophageal symptoms just because of the subclavian artery crossing behind the esophagus. As you can see in the esophagram over here, that the posterior indentation is from that.
That's a great description. We actually have a model of this vascular sling. So in this case, if you look, the aorta is coming up, it's going leftward, so it's just like normal. And then if you flip it over, you can see that the subclavian, so there was subclavians coming to the right side from the left here, and occasionally it can cause mostly esophageal symptoms. We don't really see tracheal symptoms, and that's what that light pink color is. The esophagus is getting really smushed. So as Yasser said, unusual to need an operation. You really have to show on a barium esophagram that they're having functional dysphagia, so they can't swallow bulkier things. It's very common that they have a globus sensation, meaning they can kind of feel food pass, but it still passes fine. And then if we do have that, then again, we move the subclavian up to the carotid, and then we resect this comro so they have nothing behind the esophagus. So it's a similar idea to other types of vascular rings. Well, great. I'll check if we have any questions.
While we're looking for more questions, I'll ask other, about the surgical approach. Is it always done through a lateral thoracotomy or sometime to sternotomy?
Yeah.
Because obviously, sternotomy seems like a bigger operation as opposed to thoracotomy.
Right. So the bulk of these are done through thoracotomies. So like the right arch, aberrant left, the double arches are each done through thoracotomies. It's pretty unusual actually to do sternotomy to get to these, in part because those structures are really posterior. So they're, the aorta being in the front, but the subclavian, the KD, all the ligamentum you could actually get to, but those structures are pretty far posterior. So mostly thoracotomy, which in a baby and even like, a 1 year, 1.5 year old, they have very pliable ribs. They really don't have nearly the pain either, even of an older kid. Like it's so much easier on a kid when they're kind of in that age range.
Yeah. What about if somebody is going to the OR for VSD repair and has to have a sternotomy? Are you still able to do a vascular ring repair in that setting, or?
That's a great question. So tetralogy of Fallot, about a quarter of those patients have right aortic arches, so they have naturally the arch going to the right side, and a proportion of those will have a vascular ring. So it's very easy to take our ligamentum. So that does open it some, but we're really not able to get to the subclavian if they have an aberrant subclavian to address that. But you certainly can, and it doesn't really add a significant risk, divide that ligamentum to try to open up the area.
Mm-hmm. Yeah.
Good question.
Yeah, right aortic arch and tetralogy of Fallot is a good example of because most of those will actually not constitute vascular ring, with a few exception, obviously. And part of that is that even though you have a right aortic arch and aberrant left subclavian artery, the ductus arteriosus is actually more anterior, either coming from innominate artery or typically innominate artery. We have mostly a mirror image branching pattern.
Yeah.
And that's why most of the patients who have tetralogy of Fallot and a right aortic arch don't constitute a vascular ring, but a small subset does. So that's a great example. Similarly, actually in thinking of other congenital heart defects, truncus arteriosus will not have a ductus arteriosus.
No ductus.
That can also, even though you can have right aortic arch, you can still have, circumflex aorta in these situations that can have a mass effect in the posterior esophageal area, but not necessarily a true vascular ring to repair. Obviously, when you have a congenital heart defect, the repair is also more complicated. It's not just a vascular ring where you're approaching it in the normal pathway.
You've also seen a whole variety of things that we haven't even discussed. I feel like we've seen it feels like there's almost like an infinite type. I mean, yes, these are the standard ones, these are the most common, but often you and I will be reviewing a scan that is not any of these specific bread and butter vascular rings.
Yeah, actually, one of my interests is actually just looking at the development of how these vascular rings form from the embryologic standpoint, and the work that Dr. Jesse Edwards, who was a pathologist at Mayo Clinic, is really of great interest. I recently inherited his original book from his son, so I was super excited about it, and I was actually going to bring it in here, but I figured. So Dr. Jesse Edwards, like I said, he was a pathologist who actually described all the possible vascular rings that can potentially exist. Yeah. And what he described was this model of double, aortic arch and a hypothetical arch that can explain all sorts of vascular rings, and he even predicted vascular rings that he never saw. Wow. So, and we're actually seeing those now, and we can explain it based on his original diagram, and that's the brilliance of his original diagram, where he explained that.
And just some people might not be as familiar with that, but if you can explain a little further, that relates to the fetal development, and that we start with arches on both sides, right? If you could just
so it's hard to show it without the picture, but obviously we all kind of start off with two arches, and the right side regresses and the left one persists. And which portions of the arches, which arches regress, is going to dictate, and which one persists is going to dictate what kind of vascular anomaly, the aortic arch anomaly, you're going to be seeing. And that's the brilliant. And a lot of those structures that he described as a primitive, double arch model, a lot of those are many of those vascular structures actually don't exist in one point in time. That's the other part of that. So you have development or regression of persistence or regression of portions of that, but it could be different times, and that's why you can have persistent fifth arch, which is another interesting one where you have two arches, but both on the same side, the left or the right. So it's not the double arch where you have one arch on the right, one on the left. Persistent fifth arch is usually, both on the left side, and they're usually don't have any implication. It's just an interesting imaging finding that
Yeah.
we see. Sometimes you can develop a coarctation where they both join together, but again, that's rare instance as well. Another kind of vascular sling that we didn't talk about is the LPA sling,
Oh yeah.
where
Uh-huh.
whereas the left pulmonary artery is actually taking off distal RPA instead of the main pulmonary artery, and is take a scenic route around the trachea, and it runs. That's the only anomaly or arch anomaly or vascular anomaly where where a vessel is actually crossing or traveling between the trachea and esophagus. Everything else is either in the front or the back, but this is the only one that will actually travel in between trachea and esophagus. So now if you have a barium esophagram, you can see an anterior indentation. That's the only thing that can happen. You know, I remember how I was showing you in the barium esophagram, you see posterior indentation. It could be multiple things. It's just showing you there's a vessel crossing in the back. But if there's any vessel crossing in the front of the esophagus, it's a pulmonary artery sling or LPA sling.
And we could kind of show that
Yeah.
for the audience. And this is not a PA sling, but we do have the PAs here. And so basically, you know, this is the left PA here, and it would be going around. So coming off, starting on the right side and coming around to then feed the lung, if that makes sense.
Yeah. So
Okay,
it
sorry.
kind of takes it, like I said, a scenic route,
Yes.
goes around the trachea, and that's what causes the pull on the trachea. So you have tracheal obstruction, stenosis. That's also very commonly associated with other extracardiac or cardiovascular abnormalities like complete tracheal rings
Yes,
and tracheoesophageal fistula. So many a time, more important than fixing the LPA sling is actually fixing the tracheobronchial problems.
Yeah.
You want to comment on that?
Yeah, so the tracheal rings, complete tracheal rings, means instead of having a hard part in the front of your trachea and a membranous septum in the back, they have hard cartilage all the way around, and that causes stenosis. So when you do repair it, you actually have to cut out that part and reconstruct the trachea, and that's the highest risk of the operation, not the PA sling itself. So whenever you have a PA sling, you have to check for the tracheal rings, and you repair that on bypass. Generally, they're presenting quite young, and so usually these are repairs less than a year of age,
Yeah.
usually in the infant.
Now, again, you know, that's one of those things. It kind of depends on how good our OB team is and if they pick it up, and we can actually diagnose those on the fetal echocardiogram as well. So not very common, because this is, one of those lesions that can easily get missed on the fetal echo. Not because we didn't see it, but because we didn't do a fetal echo, because it really depends on the people at the front line, which is the OB sonographers and specialists who can actually refer the patient for further assessment.
Well, I did include a couple extra slides. It looks like we have time. I don't see any more questions about adult vascular rings. So these are generally gone through like a right thoracotomy, because the aorta is on the right, and so you want to replace that area. And so this is showing excuse me, let me get that. The Comrol's diverticulum. This is the right subclavian, and then the azygos here, and then the left subclavian carotid has already been done in the neck. And basically, I didn't show it well back there, but that was basically replacing the portion of the right aorta that has the Comrol's. So that's how it's done in adults. Mm-hmm.
In the adult, there is also a risk for aortic dissection from the diverticulum Comro.
Right, very good point. We don't have a good sense of the level of risk because we don't have a denominator on these patients, but there is. It's thought that a certain KD size, like similar to an aorta that dilates over time, that as that wall stress gets higher, that they're at risk for dissection. So some people are coming for repair to decrease their dissection risk. That's pretty uncommon, and again, we don't have the denominator of that to know like what percentage.
extremely rare to see, but many times you also see some calcification in the diverticulum of Como.
Yes.
Perhaps those patients are also at higher risk.
Just to go back to this image, so you basically are going to be replacing the portion of the aorta that includes the cobrils, so the ligamentum is going to fall away. You've already taken care of your subclavian, so it ends up being an aortic replacement, and it is done with a heart-lung machine. It does have a higher rate of recurrent laryngeal nerve injury, but that's if you're 50 years old, then the tissue is not going to be as good, and you just have to replace it.
Yeah. In the adults, when you actually do the repair of the right aortic arch with the Barron-less subclavian, do you also translocate the subclavian artery, or you just do
the neck?
Oh,
yeah,
I see.
Yeah.
So, but it has to be a separate procedure.
Yes. Yeah.
Okay.
Yeah. So it ends up being 2 procedures. Yeah.
Yeah, so that's another reason why you want to do an earlier infant surgery, because it could be just one step and be done.
Yeah.
Yeah.
Well, I hope we've had some good discussion here. Yes, or anything else that you could think of to close?
Is there any
we don't have any more questions.
Okay.
I know that we had one, which was great, but we don't have any more questions here. So.
All right.
Well, thank you all for listening. It's been great to spend some time. Thank you so much, Yasser, for all your expertise, and thank you for all who joined. Thank you for our crew who helped with all the 3D models and that difficult imaging. We hope you have a great day, and contact us if we can be of any help.